So good afternoon again. And sometimes I think that when the Affordable Care Act was being written and passed and went into implementation, we forgot that if we want to take care of patients, we have to take care of our providers as well. And I mentioned earlier that, this is a pet issue for me as a physician, as a healthcare provider. How are our providers managing in this new environment? Let me introduce our panelists for this afternoon. Dr. Joia Crear-Perry, who's with the National Medical Association. She's a member of the Board of Trustees as Region 5 Chair, and she's a community activist in the New Orleans area. Worked with her a lot after Hurricane Katrina. Reverend Deidre Walton, President of the Black Nurses Association. Dr. Alison Riddle-Fletcher, President of the National Dental Association, and Deborah Frazier, who you met earlier, who's the Chief Executive Officer of National Healthy Start Association. So this panel purposely convened African American health providers from across the healthcare spectrum and continuum to engage in a moderated panel discussion about the successes and the challenges that they have faced in the implementation of the Affordable Care Act, as well as explore some short and long-term solutions to these challenges. So we're going to make it very interactive. I'll start with a few questions and then we'll have interaction from the audience. So first, very broad question for everyone. What are the unexpected challenges facing your profession as a healthcare provider that serves largely underserved communities during this implementation of the Affordable Care Act? What are some of the unexpected challenges that you find yourself facing?
I can go first if you like.
Go ahead.
Okay, so at the National Medical Association, we represent about 40,000 African American physicians across the country. And we've had a wide variety of problems that we didn't expect. And first of all, we didn't expect the Supreme Court to say it wasn't going to be Medicaid expansion in every state. And so that has created a huge disconnect between the haves and the have-nots. We have some states where they have a lot of new patients who are now on Medicaid that never had access to health care before, and they have a provider. And so those providers are helping to have patients navigate their system. And then we have other states, like where I am in the wonderful state of Louisiana, where we have patients who still do not have access. We're having privatization of public hospitals, so they're being squeezed from both ends. They don't have Medicaid, and they also don't have their public hospitals anymore. And so we did not expect to deal with the challenge of having people have not as much access as they even had before because of that outcome from the Supreme Court. So.
Wow. Anyone else?
Yes. Okay. With the National Black Nurses Association, we had a lot of work done. We had expected challenges, but one of the expected challenges continues because we thought with the Affordable Care Act and its implementation that nurses intersecting with the Institute of Medicine's report on the future of nursing, that would increase and motivate for nurses to be allowed to practice within the full scope of their training. But we're still facing challenges in getting the state's legislation to allow that. We have 50 states plus DC, but only 18 of them allow nurses to practice within the full scope of their training. But breaking news, Connecticut just passed the other day the Senate bill for that, and so they are now going to be allowed, the constituents there will be able to seek full care under a nurse practitioner. But that's still just 18 out of 50 plus DC.
One surprising trend in dentistry that we found, even though dentistry was not included in the Affordability Care Act, state by state, CHIP programs, S-CHIP programs, did include dentistry for children. However, we've experienced some inconsequential dealings with the insurance carriers in which how that administration has been carried out, which is a serious topic which I would like to discuss today. One of the things that was trending in dentistry was that there was an increase in dental Medicaid providers to the fact that within the National Dental Association, 62% of our members were Medicaid providers. So we were seeing this uptrend and being able to provide dental homes for our patients.
Healthy Start?
Yeah, I don't know that you would call it necessarily a huge challenge, but I think a disappointment for us is that Healthy Start has been at the community-based level for over 20 years. And for over 20 years, we were working with community individuals who did not have insurance. We were getting them enrolled in Medicaid, we were finding medical homes, and we'd been saying for some time, as Affordable Care Act was being discussed and rolled out, here we are. We use the phrase shovel ready. We're ready to hit the ground running and get communities enrolled and engaged in Affordable Care Act and get them enrolled in insurance. That should have been a natural to roll out to organizations like Healthy Start. And it was a huge disappointment that it just didn't happen that way. And I think it would have been to the benefit of Affordable Care Act to do it, to use organizations like Healthy Start that were already on the ground and ready to roll.
Thanks. I wanted to follow up on Dr. Riddle-Fletcher's comment a minute. With the implementation of Medicaid managed care in the early 90s, we saw African American practitioners lose their client bases to large managed care entities because they represented new revenue. Will this be happening is this happening again under the ACA, and how do we, as African American practitioners, defend against or take advantage of this new healthcare environment? Is that still possible? And I don't know if you wanted to expand on what you were saying about losing your ability to take care of Medicaid.
It is an alarming trend that in which we particularly started to occur in Tennessee that was brought to our attention in December of last year, that doctors who are traditional Medicaid providers, and these are your neighborhood doctors. This is the one, your neighborhood clinic, who've seen patients for years, have systematically been eliminated from the system due to quote-unquote terms as far as overutilization. So they felt that those doctors could patients could be seen by just as many doctors if they were to be able to spread patients out throughout the neighborhoods. The problem that we have found that when you move a child's dental home even 5 miles, 3 miles, without any type of public transportation, they're losing their dental home. What we found that what was trending with this particular insurance carrier, that they encouraged those breaking of those dental homes by asking, basically letting you know that your provider will not be available anymore. However, this is the location of a provider in which you can go. If you can't get to that provider, then that child cannot be seen. Also, which was very disturbing, is that we started really underlining and looking at the contracts in which the states sign these contracts. And to think that it is acceptable for 51% of children being seen once a year for one dental visit is ridiculous. And the incentive for the insurance carrier to save the money as far as for the state and the carrier to possibly save up to $8 million as far as incentive not to refer these children to a dental home. Those of us who were in Maryland, we always remember what happened to a little boy Diamante driver that had died from a preventable dental disease. Something as simple as that. And this is actually setting us back on that road to those type of epidemic levels again. And it's not that just dentistry. It is, we need everybody, because if it starts with one trend, and if they feel that they can save money by not utilizing for the dental care, and the money goes back for state parks, roads, highways, that's not what the money was intended for. And it's definitely not for the children. And it's not about the doctors losing money, it's the safety and access to care of the population, particularly minorities, children they don't have a choice. They're relying on us for their safety.
What about the National Medical Association?
We had a really big problem actually with Medicare because with the Medicare Advantage plans, they're starting to have networks and starting to become quite large. And with the Affordable Care Act, they kind of topped off how much money they were getting per month per member. And so what some of the plans did, some of the really large plans, and in fact the NMA partnered with the AMA on a letter to Sebelius about this, that they were releasing many providers, thousands of providers from the plan, because instead of saying we should do better care on our end, they decided, well, if you had a high volume practice with you saw a lot of patients on Medicare, we need to release you from your plan. And it's really unfortunate that we can't come up with more creative ways to ensure that people who are using the system or perhaps overusing the system can get better care by than saying, well, your provider must be the issue, so we release your provider from the plan. And so having everyone from the administration down to understand that these patients, these community providers have been taking care of these patients for years. And just because you kick them off of your panel on your Medicare Advantage plan doesn't mean that they're not going to access that provider, because their relationship is with that provider. So the person who loses is the patient. And so we really need to rethink how we provide care, more prevention, more community-based care, and not trying to decrease the money on the side of the provider issue, because you're not going to get, you're just treading water doing it that way. So,
But, you know, isn't the fact that you were seeing more patients, the fact that, you know, at least you were taking Medicare and Medicaid patients where others were not?
Right. So there have been many studies that show that even if you increase reimbursement, so part of the reason that we don't have the same issue as dentistry is because Medicaid doesn't pay very much for medical care. So even when you have panels, when managed Medicaid comes to a state, people aren't fighting for those patients, because if I'm getting $33 a visit, they don't want those patients. But even when they increase the reimbursement for Medicaid patients, there have been studies to show that only the traditional providers still care for those patients, that you don't get a huge increase and you don't get a huge uptake and new providers come into the system. So you can talk about many different reasons why folks don't want to take Medicaid, but they just don't. So you could pay them instead of $33, $60, still the traditional provider is going to see them. So most of the people at NMA have between half to 60% of their practice is Medicare and Medicaid. And so we're always going to be there. We're always the ones in the community doing it. And so really the conversations about the best ways to manage them over the years, we've been doing it when we were getting $20. And so we're going to still be doing it no matter what. So.
Trust me, in dentistry, it's not a windfall of money that comes in for providing.
Oh, no.
It is not. However, it is an access to care issue, the fact that you have neighborhoods of children and adults who look like us who need our services. And if that's the provider in that area, and if you take away those providers and then send them possibly 5 to 10 miles away, who are going to be their providers? And systematically, and it's like working together as far as dentistry, nursing, we have to work together for all of us not to get locked out and our patients not to be locked out.
And that's an issue that impacts organizations like Healthy Start, because we work to coordinate care for patients. And so when we start coordinating care for Healthy Start patients, even though our initial mission was to reduce infant mortality, we can't do that unless we make sure that the mom, the baby, and now we're starting to take care of the dads and the whole family. So we try to get a medical home and coordinate care. Once we think we have one family member in care and then another family member in care, and then they come back and go, well, that provider isn't working, or to be honest, when you want to take complete care of someone, when I saw a patient, I always made sure that they had a dental visit, and for Healthy Start, we're mandated to do depression screening during pregnancy and afterwards. So we're coordinating a whole range of services, dealing with multiple providers and different payment systems. And so every time something happens on the Medicaid side that something or someone is not being reimbursed or something is being kicked out, that complicates the entire coordination for the health care of the family. So that has a huge impact on community coordination of care for the family.
Do you want to add anything? You know, just thinking of moving their provider some miles away, when you ask individuals what is the biggest barrier to accessing health care, transportation is always one of the top ones. So if they can't access the transportation, they're just not going to get to the doctor or the dentist or the nurse practitioner or any provider.
Yeah, we saw that a lot in New Orleans post-Katrina, right? Like people didn't have cars. They weren't stuck in New Orleans just because they wanted to hang out. I mean, so poor people generally don't have transportation, and so having transportation to the doctor is one of those places. And we have never really figured out a way to get folks to the doctor. And in our small little private practice that my father's been running for 1 million years, I guess 1 million is a stretch, but for a long time, we've always provided free transportation. Because of that reason, people can't get to the doctor.
What scares us is it's an alarming rate in which, even though you're almost in one field accepting the fact that it's hard, but as far as dentistry, we've never really accepted the fact that there is no excuse for not to be a dental home. And we are purposely seeing these dental homes broken apart for profit for the insurance carriers. And if we continue to allow this to happen, either by individual audits, low reimbursements, slow pay, this is trending from state to state. And if we continue to allow this to happen, we're accepting the fact that it's okay for big contracts to come in, have these programs for medical, dental, Head Start, underutilize them. The state received money for underutilization to go back to what it's not intended for, which was for the children, the patients. And what it comes down to is lack of patient care. However, it's a win for the state, particularly if it's a state that really didn't want to accept the money anyway. This is a back way in which they can bring in the money and spend it elsewhere. And this is alarming, the fact that this is happening, and as if we're going to really tolerate it.
Well, can I ask you, do the insurance companies get a part of that savings?
At this point, they get, the insurance company itself, on one particular program, gets an initiative up to $8 million back out of a $36 million program. So I'm saying this, and I'm saying
the incentive is for them to save the money, so we need a lot of pressure on the other side.
That it's not just dentistry, it's everybody. If everybody does not look at our state contracts, who your state health provider contracts are, and it's going to take a little legal effort, it's going to take some time to see what's going on, because there's money, but it's not being spent properly. And it's definitely not being spent on those who truly need it, which are the children, and which is an access to care, and it's a time bomb that's slowly happening, in which you will see the whole purpose was not to have these emergency room visits, and then we'll see more deaths of children due to preventable diseases.
Yeah.
Dental decay is 100% preventable. 100%.
I've been hearing reports, and I guess I would direct this maybe to nurses and to Healthy Start more, about grants that are available in the ACA and otherwise not reaching African American agencies and providers, or that where barriers have been set up and making it more difficult for traditional, those that have always been working in whatever area, whether it's AIDS, Healthy Start, or whatever, to be able to access grants. Some grants not going to anyone of with any African American entity. Have you been seeing any of that?
I think for us, and I want to respond to the previous question.
Go ahead.
Before I do that, I think on the plus side, for those of us who've been in the community, we begin to know, I think as Dr. Crear pointed out, who those providers are who will see our clients and our patients. And as Dr. Crear pointed out, they are often the physicians of color in our community who we know will see our clients. For example, when I worked in New Orleans, I always knew where her dad was, and I knew he would always see my patients, and we could refer to him. But I think across the country, our Healthy Start projects know that as well. And we can always find those physicians who know our patients and know our clients and know all of the needs that they have, and they're not just a one diagnosis need, that they have multiple needs, and they'll take care of them. To your other question, I think that there is some truth to that, and I think the association is probably a good example of that. And I say that because for over 20 years, as Dr. James pointed out, our infant mortality rates collectively for Healthy Start is much lower than the national. It's 4.6 or 7. And you would think that after all of this time, there'd be some clamoring around, let's multiply the number of Healthy Starts all over this country.
Yeah, duplicate
With that kind of success, we should replicate this project. And yet we have struggled to be at level funding for the last couple of years, while other things have just blossomed, and they're struggling to get new money for those programs. And yet here we are with the success and evidence of over 20 years of and we can show that we reduce infant mortality. And I've heard since yesterday about, not having the evidence to show what you need in clinical trials. And here we sit with over 20 years of doing what we do to show that in fact we've been successful, and there's been no movement toward replication of Healthy Start. And we've struggled just to have level funding with the support of the Congressional Black Caucus and the Tri-Caucus. So yes, I would agree that there has been no grant money and no federal effort to replicate what has been successful in communities of color, and you cannot address disparities unless you're at the grassroots level in communities of color.
Right.
I was going to speak to the Title VIII programs that have been modernized and expanded to include and encompass programs that are going to, particularly in the underrepresented areas, to allow those nurses to achieve baccalaureate degrees and advanced degrees, and also programs and giving priority to those programs that stress as a priority quality. And then they have programs, the geriatric programs for those interested, because we have older Americans. And so there are programs under Title VIII that have been enhanced and to provide more flexibility as well. And what it's going to take is for nursing organizations such as the National Black Nurses Association to educate nurses across this country, those who want to go into nursing and those that are already in nursing, about these programs and grants to help them to receive those fundings.
I just want to piggyback just a little bit on what you said. So for outreach and enrollment, the National Medical Association got not $1 to help patients out should enroll. And I think you said the same thing about you guys. And recently at our colloquium in March, our president, Dr. Lenore, announced an initiative with the National Association of, with Enroll America, who actually did receive quite a bit of money for outreach and enrollment, and with the Black Church, that we were going to partner to help do outreach and enrollment. So once again, we're doing it out of the goodness of our hearts, us in the church. And that is a shame that we have to always be doing things out of the goodness of our heart. So,
when there's money.
when there's money available.
When there's money available. And a couple of you touched on culturally appropriate things, and many individuals, particularly African Americans and Latinos, are being insured for the very first time, and the Affordable Care Act is an obvious benefit. One challenge is addressing and managing complex chronic diseases and providing education on preventive care. The goal is a medical home, but culturally, linguistically, and health literacy level appropriate education is needed for this population to understand preventive health and preventive health visits rather than emergency visits, which may have been the history or the norm. How do we, as African American providers, ensure that we're part of the solution in that area?
We
Without
need
money.
to start.
Out of the
You
goodness
gotta
of our
get
hearts.
some money. I know.
We need to start talking to each other. We need to, for the longest time, everybody was kind of in their own pigeonhole. We need to start talking to each other and working together, because there's so much we have in common that if we have a collective goal, I think we can accomplish so much more. It's just that everybody has their trend in which the direction they're going. And what I'm noticing, and by talking to different physicians, they're like, oh yeah, we talk about these plans, but we've been locked out for years. That's not tolerable anymore. We cannot allow ourselves to be locked out anymore, because our patients are suffering, our programs are suffering. And so we have to, which we have definitely taken a start in communicating together, that as collectively as a whole and as a group, we need to come together as a force and say, no, we cannot accept this anymore. This has become a civil rights issue in which we cannot just accept that money is just being used not on a patient's. It needs to be used on which it was the purpose for which it needs to go. I'm sorry.
No, you're hot.
No, I was going to say, we just recently met together, the dentists, the physicians, and the nurses. And one of the things that I as the nurse, recommended in our coming together is that rather than throw things against the wall and whichever sticks, is that we identify the top priorities, one or two, and then and look at and what strategies were implemented and that we provided, and look at and then measure the outcome. We already have the data. It's out there, but we need to focus in, narrow it in, and then come together collectively to see what works.
It almost seems like we need to, what was the group that included the lawyers? Remember, every so often we'd have
The Black Congress on Health Law and Economics.
Black Congress on Health Law and Economics. It sounds like we need to bring that together again, because they may need some legal action to be taken.
Well, at
as
this meeting, it was the physicians, the nurses, the dentists, and there was a lawyer that was with the Black Congress on Health Law and present at that meeting. But again, we need to come together, like she says, and come, and strategically approach the problem rather than, doing it haphazardly.
The Affordable Care Act did provide a greater opportunity for a range of medical services. Have you found that it has made referrals for mental health services any easier? Have you seen an impact, a favorable impact on making referrals for mental health services? And I know the Black nurses have been involved in mental health, depression issues for a long time.
Well, one of the things that I've been involved on the West Coast is working with PCM, patient-centered medical homes and accountable care organizations. And included in that model, we did a shift from acute care to chronic care. And a part of that, and on a team, you must have behavioral health both nurses, social workers, as well as psychiatrists to address the total person. And what I like about that chronic care model is because it's preventative, it's proactive, and we visit patients in the homes. If they can't get to where they need to go, we have physicians that actually go into the home to see them.
So two things. One is that in Louisiana, we've separated out managed Medicaid for medical care versus managed Medicaid for mental health. And so we once again have kind of ostracized or set aside our mental well-being from our physical well-being. And clearly, you can't have one without the other. When you don't feel well, you don't, you don't respond. So it goes both ways. So they're rethinking as a state. I was recently in some meetings around how we're rethinking how we do that RFP process again to include mental health. And so I think that across the country, so what the ACA, so although today I can't say that I can get into mental health services more quickly because it's actually a conversation that's happening more. And also primary care providers, we've been talking about this for a long time, that we can't have mental health just be for psychiatrists and psychologists. You know, as an OBGYN, I would say 90% of what I did was mental health, but I don't know if everybody else would agree. Talking to 40 women a day is a lot of mental health. So no, we have to learn how to be comfortable with diagnosing depression, diagnosing small mental health issues, and being able to refer. Having 15 minutes with a patient is not enough time to actually do counseling and therapy, but it is enough time to get it started. And so changing the trend of how we train primary care providers to do more mental health screenings, like in Healthy Start. I was the medical director for the New Orleans Healthy Start for a while, and we had to do the pre and post test, and then we would get this information. People would have mental health issues, and we had nowhere to refer them because there weren't enough providers of those services. So.
See, that's the thing that we found that not so much weren't enough providers. We didn't have an accurate listing of providers that were. That's the whole thing. Is we need to improve our networking as far as if there are providers there and that are available, access to the proper providers. And then everybody goes, well, we don't know where to find you.
Right.
And that was a major stumbling block for getting access to care to patients.
Yeah, but it's funny because even going to Medicaid managed rollout, you suddenly have all this computerized data set, right? So it'll say that we have 300 orthopedic surgeons in New Orleans who take Medicaid. I can't get an appointment with one, so I don't know who these people are. They're on this website, so it'll say I have 1,000 mental health specialists in New Orleans who take Medicaid. I can call them all and try to get an appointment tomorrow. I can't get a one. So just because you're on the website and just because you're listed as a provider in a plan doesn't mean that the person has access to that care. So
one of the successes of the patient, the medical homes where I am is we have the assessments. And in that assessment is just not looking, did they get their LDL or their hemoglobin A1C? Did they get their foot exam? Did they get their eyes exam? They do a depression screening. So you're looking at that total body, and if you're a woman over 50, even though you're being screened for diabetes, they're going to ask and look to see that you had a mammogram. And colorectal screening, all of that, and that's part of the success, and that's in the target population management, and closing those gaps is looking at all of that rather than just, at one thing.
Yeah. Okay, I'm going to ask one more question, and then I'll turn it over to the audience. And this one may be a bit controversial, but it's come up even here in the last couple of days. Proposals have been circulated by the administration and elsewhere to cut payments for Medicare bad debt. This is likely to have the biggest financial impact on hospitals that serve more low-income people. Similarly, there's an active debate, and this is the one I really want to get into, right now about whether there should be risk adjustment based on race or poverty in programs like the Medicare readmissions penalty program. Ironically, both sides of the debate are arguing that their position is designed to benefit low-income patients. The anti-risk adjustment camp says they don't want to set up a two-tiered performance standard that accepts worse outcomes for certain populations. And the pro-risk adjustment group says failure to risk adjust just takes resources away from providers that care for more poor people, and that those providers are already under-resourced. So any thoughts on that issue?
So I just read this article. It was interesting because it appeared as if the administration had paid for a study and then didn't particularly care for the outcome of the study. So that was my take on the article. If you risk adjust, if most of my patients come in and their sugars usually run when they come to see me in the 200s, and you penalize me because my patients' sugars are not in the 100s, and you have another practice who the people when they come in general their sugars are about 130, and then it's difficult for me to say that we have a comparable population. And so although I've lived in a state that we've had a two-tiered system, so that's the language we use around Charity Hospital, right? Like we have a private system and a two-tiered system. But I don't see how you can get around risk adjusting, at least for a differential. And so instead of saying everybody should be under 100, you should have an improvement, based upon you get a certain percentage improvement. And so that you have a goal. If I tell someone to go get a mammogram, because the most common reason OB-GYNs get sued is breast cancer, right? Because we say go get a mammogram, but I can't physically put you in my car and drive you to the mammogram place. And if you have an hourly job, and if you have 3 kids, and if you have all these things to worry about, the thought of remembering to be able to get this mammogram done just doesn't happen as readily as a person who has more resources and more time. And so to me, what needs to change more than penalizing doctors or figuring out the risks, whose side are you on, is the system changing to making it more convenient so that people can actually get paid to be off work to go get a mammogram. But the system changes so they have convenient hours on the nights and on the weekends for mammograms. So we keep shoveling the money around and arguing amongst each other, and we're not actually changing the system for the people that it works upon. So that is my take.
Okay. Any questions or comments from the audience?
I do have my shameless plug.
I'm Renee St. Anthony from the great state of Nebraska, where we didn't expand Medicaid either, Dr. Perry. I've been making it my business to talk to people who are not the choir about health disparities, the importance of the ACA, and the importance of all of us as a society and community to really care about achieving health equity and how everybody has their role in doing that. And I want to share with you a conversation I ended up having, which was quite embarrassing and took every lesson I had in diplomacy to have this conversation with a particular person in the audience. So I present most of the data that you've seen over the past 2 days. And afterwards, someone asked me, they said, well, if African Americans only represent 12.5 to 13% of the population, then tell me how it's equitable that you eat up more of the budget than 12 to 13%. And of course, I give them, we have this is a sequela of slavery, and this is how much it costs, and the economic reasons, et cetera, and that it's a collective good, but it's also an economic impact to actually address these health disparities. And by doing this is an investment, and you should get a return on your investment. And the response was, well, that's why we need to have these stringent immigration laws, because we can't afford to have these Hispanics come in since we have to keep the black people. And it took everything inside of me not to say, well, I guess this is your karmic price. You must pay for the consequences of slavery. Of course, I didn't say that. I said something along the lines of, I'm happy to have this conversation with you offline. So I would ask each of you, how would you respond to a person who is coming from that perspective, especially after hearing comments like from Donald Sterling this week, and knowing that people have these deep-rooted, and I was actually grateful that he could stand up and say that, because there are a lot of people in rooms who are thinking this way, and how do you address those deep-seated, sometimes unconscious biases? Thank you.
Well,
That's the easy question.
For the National Dental Association, we have an advocacy day which will take place actually May 8th, in which a lot of those, as far as understanding, I should say, and issues that particularly deal with African American issues, and as impassioned as it is as far as in dentistry, how it affects all of us. And it's not just, it's people of all color and all social economic rank and file that this affects. Even though it's easy just to be able to pull out certain numbers in certain races, when you help one, you help everyone. So I find it interesting when they were able to just pull out those one particular statistics. But if there's a situation where a whole group, particularly Asians, Native Americans, are benefit, it's just not one group, it's everybody. And so we were welcome to come join us on our Advocacy Day at the Hill. The National Dental Association, you can go online, nda.org.
You know, the hard thing about race is a visceral response, right? Like it's not a response that starts with your head. It's a gut response. Like when I see certain people or certain spaces, I respond unconsciously to those activities. So a lot of times the things you hear from people, they are not even aware, and I know I'm probably giving them a pass, but they're not even aware because it's so visceral and it's so inside of them. And so really acknowledging the fact that they feel a social and linguistic threat, that they've kind of accustomed to having black folks around, and they, you know, if we start talking about slavery, they totally shut off because they don't even want to hear about that. They want us to, as one person told me once, get over that. Y'all are here now, go back if you don't like it and all that stuff. But then when you start talking about Hispanics, they really get upset because it's not only just having a different skin color, it's a different language. It's a set of, you know, we've kind of assimilated, so we do certain traditions that they're more accustomed to. And so this feeling of being a minority, which we understand because we've been a minority in this country all our lives. So the thought of no longer being in the majority threatens people and it scares them. So it's going to a non-threatening stance, making them feel comfortable about, okay, I understand what you're saying. Now sometimes it's still unreasonable. Usually, I mean, imagine that I speak in front of the Louisiana State Health and Welfare Committee. Last week when I spoke, there were 4 bills to stop Obamacare from being implemented in the state. I mean, this is where I live. And so they usually say, I want the pretty little young doctor to come back up front. I mean, this is the language that I have to still sit and look present, but I usually make it an economic conversation, that if we don't do this, we are not economically competitive as a state. If we don't believe that people should not live 25 years less than their cohorts, we cannot get jobs for the offshore oil rigs. We can't, you know, all the things that they care about. I try to put it in that lens. But I know in my heart that they can never see me as an equal doctor as their friend Bubba, who went to med school. You know, they just don't see me, and there's nothing that I'm going to do to make them see me that way, and I'm fine with that, you know, so.
May I answer from, with the National Black Nurses Association, where we have focus on different areas, but one of our focuses that we have is in relationship to policy, health policy, because we can't just be about, you know, going and taking blood pressures and things like that. We have to be politically aware and astute to help make policy rather than to react to policy, because it's going to impact that nurse at the bedside. Mm-hmm. And so we've been going to the Hill for 26 years under Congressman Stokes. We have what's called the Black Nurses Day on Capitol Hill that was in 26 years ago, was named that in Congress. And so we keep that at our forefront and educate our young nurses that are coming along. You must be an advocate for your patient, not just by looking at health disparities, but being politically aware and health policy astute.
From our perspective at Healthy Start, and I would agree with a lot of what Joia's had to say too, because you have to step back and not take the visceral approach, which is sometimes my first thought. My husband is more intellectual, and he tells me that that's why I don't watch Fox, and he does, because you have to know what everyone is thinking and saying.
That's true.
But from where we sit, infant mortality, and we say it's twice the rate in communities of color, but in many communities it's 3 and 4 times the rate. Mm-hmm. If you go to the Delta, if you go to some inner cities, if you go to Appalachia, it's 3 times as high. So if you can make that argument, if you can start talking about the fact that women are dying in childbirth, and many people don't know that still exists. Find a common ground where you can talk about something compassionate, that it goes beyond just race. There's a human compassion to it, and find common ground. And the presentation that Dr. James did this morning, I think lays it out in a way that when you talk about 400 years, you can hear, and I've heard different people present, even presenters here talk about first or second generation having come to this country, but we all didn't come to this country the same way under the same circumstances. Right. Mm-hmm. And so the way Dr. James has laid this out for us, in the presentation he did for National Healthy Start, it was about an hour long, and it had different slides in it, but it shows how we didn't all begin the race the same way. Mm-hmm. And so in that presentation, there were people in the audience, including some from HRSA, who finally, I think it was like a light bulb, they've been talking about and researching issues of disparity and equity, but I think it finally may have clicked in a way that it hadn't before. So if that helps you at all.
Let me try to get some other, I have about 5 people standing. Mm-hmm. Yes, ma'am.
I wanted to remind us of the question of how healthcare providers are doing, right? And a lot of our healthcare providers are not doing well. We are not healthy ourselves economically, providing care in communities where a lot of times we're the only one, or we're one of a handful where we all know each other, right? A lot of our healthcare providers are not compensated fairly, and we watch our colleagues across town who are compensated at rates that we can't even get in our contracts. There are unfair contracting amongst some of the MCOs, right? And some healthcare providers, if they're not in the right network, they never find out about it, right? They will practice for years and never know that the same exact service 5 miles away is being compensated double what they're making, right? Because they don't have the lawyers to help them to negotiate these deals. And the other thing is standardized pricing in our healthcare service. A service should be a service, right? And we have facilities when we open private practices, but we're not allowed to be compensated to help keep our facilities open. We have staff, and a lot of times we're the largest employer in the community that we're serving, and we pay living wages to most of the people who we're employing, or all of the people in the case of Core Health and Wellness Center, because it's one of our policies, right? And I want to just remind us of this, because as we advocate, you know, as organizations and associations, I think we also have to be really honest about the death of the providers. What is the life expectancy of a healthcare provider in a minority community who chooses to have his or her practice in that community? I think when you start to look at that, you'll see that we're not doing well at all. And the last thing I just want to encourage the panel to maybe talk about is the death of private practices and what that will do to our communities. We must start to advocate for small business loans, for new providers to come in the community, and it doesn't matter if that's a nurse practitioner, physician's assistant, dentist, physician. If they want to hang a shingle in our community, they should be able to finance their office, and they should get loan repayment forgiveness of a small business loan, just like we do our other loans.
Anyone want to comment? I mean, I think it's pretty, so, let me go to the far end, because all of those are great ideas.
Good afternoon. My name is Beverly Morgan, and I am the president of the National Federation of Licensed Practical Nurses, and I'm also a member of Black Nurses. And I wanted to just make mention of one commonality that in every aspect of the presentations today was about mental health. One of the initiatives we've taken in both of the entities that I'm familiar with is that we are doing mental health first aid training so that the nurses in this country have a great understanding and be able to identify when some of our patients are in crisis. The one thing I asked the panel, how do you, in your perspective areas of expertise, create legislative changes so that there is payment and reimbursement for the services that are definitely needed in our country, and that we've said in every aspect of what we've discussed today would definitely be helpful to the quality of life of the people in this country.
I mean, when Joia was talking, and other panelists throughout the day have talked about 15 minutes and 12 minutes, you know, that's an issue that really needs to be addressed. I don't know how you do it. I was in a solo practice. I rarely had a 12 or 15-minute visit.
Exactly.
I just didn't get paid. So we really have to address the reimbursement to allow healthcare providers to provide what the patient needs.
Right.
And it can't always be done in a 15-minute visit.
And I remember explaining this to a member of Congress, not you, of course, so the way we're reimbursed as providers is based upon how much time we spend. And if you look at it, for an hour, so when I use $33 in Louisiana, for an hour-long visit, you get $33. And so, you know, of course, we're not spending a whole hour. It's also not just about time. It's either time or the number of things that occur in that visit. And so if you're a psychiatrist or a psychologist, you really have to use the entire hour. Like, you can't say, I did a bunch of stuff and I only talked to her for 10 minutes. Like, you have to sit there and actually do therapy for an hour. So you can't afford $33. And so the mechanism that other providers use to be able to survive, so, you know, $33, if you only had an hour, you got to pay rent, you got to pay employees, you got to pay, my malpractice insurance was $80,000 a year. I could not spend an hour for $33 on anybody. So, you know, those are the kind of realities that we have not even begun to address when it comes to mental health care. We're not reimbursing for people's services in a way, that a meaningful way, that anybody, that's why there might be 1,000 people listed for mental health, but nobody's taking Medicaid because they can't take $33.
Right.
What are they going to do with
Or
that?
they'll take 2 or 3 and then
Right, to say that they did it, right.
Yeah. Yes, sir.
Bob Griss with the Institute of Social Medicine and Community Health. I think we're talking about accountability in the healthcare delivery system, recognizing that the patients that you're seeing are living in communities where there's greater poverty and where there's poorer health. And yet you're competing in a marketplace which rewards efficiency when you don't have control over many of the social determinants of health that influence the outcomes that your patients exhibit.
Right.
And I'm thinking about the way accountability was handled in the Medicare program, which was not on Daniel's timeline, but I think is the most significant event in our history of healthcare from an accountability point of view, from a health disparities point of view. And that was when Medicare came into existence. It basically said to hospitals, you may have been discriminating for 200 years, but you can't do certain things anymore if you're going to collect Medicare dollars. And because that financial incentive was so great, throughout the South, throughout the whole country, but even in the South, you had all the hospitals, just about all of them, no longer practicing the way they did before in terms of segregated health care. What I think we need to do now is figure out an accountability system that ensures that disparities are eliminated, whatever it takes, and not leave it to what the doctors have control over, whether it's the amount of time they have with the patients or even the clinical processes that they have. Like you said, you can't ensure that somebody goes to get the mammogram. You can't drive them there if it's against their will. But if the community is reinforcing certain standards of care, I think if we had a mechanism where savings in health care could be redirected to social determinants of health at the community level through a democratic community health planning process that would ensure that that $800 billion every year, according to the IOM, which is non-productive use of healthcare dollars, most of which are public dollars. 60% of total healthcare expenditures are public dollars, but we don't have an accountability mechanism that ensures that standards of care are equal, and particularly in terms of outcome. And I think this is really where we're dropping the ball on healthcare as a civil right. To me, this is where the leverage needs to come from. And it will take different forms in different doctors' offices, in different communities. But it requires the state, you see, to have that obligation to ensure that resources and regulations are directed at eliminating disparities. There's no other way to think about it.
Right. And going back to her earlier comment, I just want to agree that, yeah, the private practitioners are struggling and they're falling apart, and we have a big divide in that. I just wanted to acknowledge that, and we do address that in NMA. But what you're describing is what we're trying to do with the nonprofit hospitals right now, right? Like, so you have this whole IRS regulation, and you say you don't pay taxes, and you're supposed to invest in the community, and so the first step was they had to do a community needs assessment. So they all put one up on their website. They hired firms, and they paid firms $500,000 to come and make a list of all the community assets and the community things, you know, in their communities. And the next step was to say, now that you have this the assessment, now you have to do a plan. So they're supposed to gather community members together, and they're supposed to create a plan because they don't want to pay these taxes, and they're nonprofit, and what does that mean as a hospital? Benefit. So they have to do a community benefit plan, and so you know, that's where we are now. So because this is what I do, I email them all in my community, and I say, I'm the president of the Black Sisters Association, I want to know what you're doing. None of them have come up with what's next. There's supposed to be penalties. We're talking about billions of dollars that should be reinvested for parks and for transportation. They could every person, if they use that money just to give a free ride to every person who needs one to get to the doctor, that would solve a bunch of issues. And so what they've historically done, is most of you probably know, is write off bad debt. So that day is over. The president has said no more. So we shall see where that goes. Yeah.
You know, and getting Congress to count the savings in a program, in a prevention program, has been extremely difficult. I have bipartisan legislation to do that. The discussion around what they call dynamic scoring, which is very vague and not as specific as what we're talking about. We're talking about really demonstrating that if you take care, for example, of a person with early renal disease, you can save so much because you're spending 10 times or 100 times as much when they get to end-stage renal disease. So if you can demonstrate actual savings, we want it to be counted and be used to pay for the kinds of other programs that we need. So we have that legislation, and then the other initiative that the Congressional Black Caucus has is the 10-20-30 program that is Jim Clyburn's initiative, that 10% of all funds, all programs, go to communities that have had poverty levels of 20% or more for 30 years. And he was able to get some of that into the American Recovery and Reinvestment Act, but we've not been able to get it in any budget or any appropriations bills thereafter. We're not giving up, but we haven't been able to do it. And when you look at it, I think it's 2/3 of the communities that would benefit from this are Republican communities.
Exactly.
But it's a way of beginning to address some of the social determinants and of, oh well, I'll get to that later. So, next question.
Over here. Thank you to the panelists. Answer to question earlier, life expectancy, black male physicians, 58 years.
Yo.
Okay? So just so that everybody knows, that's the answer to that question. Wonderful idea about SBA, and maybe somebody in their new exchange website we'll talk about how we get to that point, because already SBA's under fire with this president because they're loaning less than 3% to African Americans. So those numbers need to improve in general, but we have to get to a way so something can happen so we can encourage those going into medicine to go into private practice. These days, doctors are more responsible, being made to be more responsible for more things, and I feel like patients less. By the way, I'm a general intern in the South Side of Chicago, black middle class neighborhood. I get faxes from pharmacy benefit managers, your patients, based on refill history, not taking their meds. Case in point, last day I saw patients in the office, Thursday afternoon, saw 12 patients, 5 admitted to me they hadn't taken their meds like they should, okay? So that's almost 50%, but it's my fault. And, you know, when it comes to blood pressure control, I'm getting dinged. You know, first patient of the afternoon, I couldn't afford that medicine. Okay, I saw you January 31st. No phone call. You know, so when she left the office, I'm doing the electronic refill, but no call to the office saying I can't afford that medicine. But I'm responsible. And I'm responsible when their cholesterol is not under control because they're not taking their statins, or the diabetes not under control, you know, for not taking those meds. Dr. Davidson in the endo-diabetes lecture yesterday talked about they're not in control, bring them back every month. So I've been doing that for a few years now, and they think that becoming an ACO or belonging to one and getting paid based on the diagnosis is gonna make things better. I don't see that. I'm not gonna stop seeing patients every month if their A1C is more than 8. It's not, you know, it's not gonna happen. It's not gonna make me get paid. I'm not doing it, having them come every month now because I'm getting paid for that service. I'm doing it now to prevent them from losing a leg or their sight or being on dialysis. More reporting, meaningful use. In addition to other things that some of you all may not be familiar with that we already have to do in order to, so we don't get pay cuts right now, like e-prescribing, PQRS, PCORI, all kinds of things. But meaningful use you may have heard of. And meaningful use too, we got to get the referral. I'm a primary care physician. We got to get a referral letter back from the specialist. You know, of course, my patient's going to see the breast surgeon because they got a breast cancer diagnosis. We're following up on anyway. But somebody got knee pain, I want to send them to an orthopod. Meaningful use too says, I got to make sure I get the referral letter back, not that that specialist has to make sure they get me the referral letter back. And so, like my colleague here stated, we got to look at us and, you know, the things that are causing us to go out of business. You know, some of it is just some of the frustration that you hear. And of course, we've been mandated to have these electronic records, but to not lose money, but they don't talk to each other. You know, and so, and we can't make them talk to each other. And the feds aren't making them talk to each other. And it's just, you know, at some point, you gotta, somebody has to say something about, you know, the need to help physicians, you know, and other health care providers instead of doing things that are driving us out of business.
You know what I love about this conference? I've been coming since Katrina, and one year you had a person on here who was from from Europe, and they separate out kind of the European, how they, so if a person has poorly controlled diabetes in Europe, they don't blame the provider, they blame the system around, you know, they look at kind of what the neighborhood looks like, what the infrastructure looks like. So we haven't gotten to that place yet in the U.S. where we look at the built environment. We're still looking to point fingers at individual people and hospitals and other things instead of really changing how we look at our whole community as a system and addressing those things. And so it makes people have to, you know, go out of business, live shorter lives, have strokes, have heart attacks, all these things, have more malpractice, all these things because they're trying to just keep up with added on more regulations, more paperwork, more things, and without really looking at the systemic reason why they're having problems. So.
And I want to say, and there are things that we know already that works. You know, we're hearing from this woman at the podium, I'm sorry, at the mic, and we're hearing from Dr. Crear. We know that physicians don't have time in their office to do all of these things. We know there are community-based programs like Healthy Start that use community health workers who are from the same community, who are basically translators. They know the community, they know who the providers are, they know what the community needs. They can take her patient, they can take Dr. Crear's patient. They can coordinate the care. They can make sure they get mental health, they can make sure they get dental health, they can make sure they get transportation, they can make sure they get all the health services that they need and get them into providers at a cost less than it's going to cost to do anything else. We know that works already. So we can invest in what we know already that works. And there's no excuse for not investing in what works.
I'll get back to that in a while. One more question.
Yes, Alma Roberts, Baltimore Healthy Start. My question is about the federally qualified health centers. Billions of dollars are being poured into this traditional network. How are they, what role do they play in this whole scenario of saving the providers, if you will, the traditional providers of care?
You know, I said this recently. I mean, this is the luxury of being me is I've worked in all those things. So I ran some FQHCs and I also run a private practice. And we were always battling each other. I said, you know, we got enough poor folks to go around. I'm sure we can figure this out. The traditional, FQHC is still an employer. And you can't make somebody employ you. A lot of the reason that people like my dad and other folks always went into medicine is because it was the one thing a black person could do and open up their own shop and take care of their own people and nobody really bothered them. So if you were a good doctor and you worked in Anacostia, you can be a good doctor for a long time. And so the FQHCs have a great network. They have huge political infrastructure. They have great connections to their Congress people, their senators. Some of them, I mean, the ones in Boston are incredible. They have, you know, all kind of community work, and so they have been able to really build a movement. And NMA, just recently, we're working to do more work with FQHC. We have many providers who are, the chair of the board of the FQHC, that physician is a member of NMA. So we have so much overlap. We have people who are private practitioners, we have people who are FQHC, we have people who are academic, we have people who are corporate for Aetna, all in one organization. And so the goal for all of us is to make sure that people of color are healthy and that our providers don't just live to be 58 years old and that we work together. And so they are one piece of a very large puzzle. They're a very powerful political piece that I could tell you the NMA doesn't have all that kind of on our infrastructure on our own. And so if we can figure out how to work together more with them as an organization, that would be to the benefit of everyone.
Anybody else? Not for you.
Never for you.
It's the last question.
Two quick observation. Thank you. I'm Shirley Nathan Pulliam, legislator from Maryland. I think the young lady that I heard before when she asked her question about the 12% of the population and the answer, I would have loved to have told them that of the major diseases, okay, the mortality and the morbidity rate for African Americans and other minorities far surpass the 12%. If you look at cardiovascular disease, in some of the states it's up to 60%, even though the population may be 12%. So there's different ways that you could possibly answer that question. Okay, now on the CHW, I just heard Ms. Frazier talked about the community health workers. I had legislation in this legislative period because in the ACA and in other areas, they're looking at community health workers and the role they will play. But some groups have blown it up out of and become like panacea. This is going to fix this. Right. Okay, and we had to make sure we go back and look. They wanted certification and reimbursement. And I said, wait 1 minute. The call I'm getting from nurses and social workers says, these groups are infringing on our scope of practice. So we need to make sure we know how they're trained. So the bill that I put forth along with the senator on the other side is to say that we have to first train and then we can study the certification and reimbursement and how that impacts the community health workers because they are non-clinical health workers. So although you may train them to do things in terms like with sickle cell patients or with different patients in different areas, we need to make sure that licensed health professionals are in fact observing them. So they're not out there trying to practice on their own. Because we're putting them in communities that already have high comorbidities and problems. So that is one aspect that we need to make sure we remember. And as to the community, my final last statement about the hospitals and the rates. In Maryland, we have an all-payer system. What they have done recently is that where hospitals were more or less capped at about 7 million, the HSCRC, the Healthcare Cost Review Commission, have increased it to about 12 million. But what happened, it looks good up front. So we can keep some of this money. But what happened if the admission rates, if they have more, the best way they can keep the money is to reduce the admission rates so they become more efficient. But my concern is some of those communities, hospitals, that have surrounding them, people that are very sick with high comorbidities, and how are they going to keep them out unless they have good partnership with other community services like adult medical daycare, like other groups that can really monitor them carefully to make sure they're not readmitted. If not, they're going to go under, and we're going to see more and more hospitals in those areas close. I thank you.
Well, let's give our panelists and all of the top folks who gave comments a round of applause. Thank you very much.